started?
I think so. Okay. It gives me great pleasure to introduce Dr. Madeleine Muller. She's a family physician and senior lecturer at Walter Sisulu University, and her focus is on clinical practice and medical education. She provides clinical service at Cecilia Makiwane Hospital in the East London area, where she also teaches and mentors medical students, registrars, and medical officers. She's completed her master's in health profession education at Stellenbosch last year, and she serves as the convener of the CMSA Diploma in HIV Management and is an active member of the CMSA Senate Exams and Credentials Committee, as well as the College of Family Physicians Council. Additionally, she contributes to the National CMSA and SACOMD committee, focusing on the implementation of workplace-based assessments in postgraduate medical education in South Africa. Dr. Muller is also part of the team responsible for rolling out the Supervisors Workplace Assessment Teacher Training, that's a SWAT, for clinical supervisors across all 9 South African medical universities. She is on the steering committee for the South African Association of Health Educationalists Eastern Cape chapter and is an executive member of the Rural Doctors Association of Southern Africa, where she oversees the mentoring program and manages the onboarding program. And in fact, this is her baby, which she created over 4 years ago and is still growing and going strong. She serves on the executive board of the Professional Association of Transgender Health in South Africa, with a strong passion for inclusive clinical care, sexual and gender health, and medical education. Dr. Muller is dedicated to curriculum development and fostering the growth of emotionally competent, patient-centered clinicians. And she's here today to talk about supportive learning environments for workplace-based learning.
Thank you very much, Steph. I think I'm on too many committees.
Yes, I think so. You make the rest of us look like mere mortals.
They all are like these long names. Thank you very much. I'm just sharing my slides. I'm assuming that's nice and visible.
Yes, we can see the slides.
Okay, great. Okay, great. Thank you very much. Thank you very much, everybody. We're in week 5 of rural onboarding. And normally we have our sort of soft topic for the last week, but we've actually swapped them out. The pediatric session will be in week 8. And so I'm very pleased to actually be bringing this topic a little bit earlier than usual. And at the moment, very topical, as we are in the process of rolling out work-based assessment as part of postgraduate education in South Africa. So there's been a real commitment from both the Colleges of Medicine of South Africa as well as SACOMD, so that's the deans of all the 9 universities. And I think you will start hearing, especially those of you that are interested in specializing, will start hearing more and more about WBA as you go along. So the 2025 focus is very much about starting to train up the clinical supervisors that's going to be providing WBA in postgraduate education. So one of the challenges when registrars are specializing is that the people who teach them are the other doctors in their teams, consultants, etc. And although we all get training, obviously, on medical aspects, there's actually not been very good training and capacitation for the teaching and assessment side. So as part of that clinical supervisor course, we've now created, it's a 2-day course, look out for it, it'll be coming to all the different universities. And this topic that I'm doing tonight is actually part of one of the modules of that clinical supervisor training, starting to look at how we create affirmative work environments for clinicians. So I'm going to look tonight a little bit and show you that the reason why we're doing it is actually all to do with preventing medical errors. We're going to talk about a new concept called emotional competence, which is what is needed if you want to create an affirmative or supportive working environment. We're going to talk about how we build appreciative feedback cultures. And then if we have enough time, I've got a little quick one sort of little set of tools, practical tools I would like to teach you that you can actually use in practice. So firstly, let's just look at talking a little bit about medical error. And I'm going to take us back to 27th of March, 1977. And we're going to have a little airport story. Some of you might be old enough to remember this. And the state is famous for the worst aviation accident in history. So what basically happened, it was at Tenerife. There was a lot of flights that had been diverted to Tenerife. There was heavy, heavy fog at the time. And the KLM flight took off on this runway that was completely covered in fog. And as the fog lifted just before they took off, they noticed that there was a Pan Am flight right across the runway, stuck across that runway. And the captain tried to leapfrog the Pan Am, but his landing gear was obviously still out, and the landing gear took out that central part of the Pan Am, and the KLM crashed in a big ball of flame on the other side. Very dramatic. And the man of the moment was Jacob van Zanten, who was known as the chief pilot of the KLM Royal Dutch Airlines, the corporate vice president. He was actually the director of safety, and he was a great guy. He was somebody everybody liked. He was a family man. He had more than 30 years of experience, and he was the one that took off on this fateful day on that runway. When they listened to the black box, because everybody in the KLM flight died, it showed that both the co-pilot and the flight engineer at separate occasions voiced concerns about things that they were sort of hearing over the very confused, garbled communications that was going on. But when the captain overruled them, they had both backed down. So there was sort of inklings of something not being quite right, but the captain was convinced that they had flight clearance and that the runway was clear. So what makes the story interesting is that traditionally, when you look at a story like this, you would assume, let's nail this captain to the ground. Clearly, Jacob van Zanten had made a mistake. But when KLM made their investigation, they also focused on the fact that there was actually junior staff in the cockpit that could have more actively intervened when they noticed that something was going wrong. And so their conclusion was not to blame Jacob van Zanten, but to blame organizational culture that didn't catch the mistake. So KLM said, well, if Jacob van Zanten can make a mistake, anybody can make a mistake. And maybe instead of now just blaming van Zanten for not being perfect, maybe we need to actually look at the kind of culture that didn't help him catch that mistake. And the two things that they identified is that the captain, and you can imagine in our settings, the clinician is always right, and a culture that discounts the value of the crew. So if you can also imagine in a theater setting, for example, you might have a big confident surgeon who's got 30 years of experience, and you might have a junior anesthetist or a junior doctor who's actually assisting. And what kind of culture do we have that makes it possible for the junior doctor to actually query the senior surgeon within that theater, for example? So this had happened in the 1970s. During the 1980s, there was actually huge changes that happened in the airline industry, where they were looking at how to make the airline industry safer. And there was actually, as the medical fraternity, we actually looked at what the airlines was learning. And in 1999, the Institute of Medicine actually brought out a report called To Err is Human, very worthwhile reading, about building a safer health system. What's interesting is that although we've understood this, that we need to look ourselves at our own organizational culture, we did not do the same due diligence as the airlines. So between 2000 and 2006, there was actually no deaths on major American airlines during that time. But during the same time, there was an estimated 250,000 to 500,000 people killed from preventable medical mistakes in American hospitals. So that's the equivalent of crashing 1,400 fully loaded airplanes with no survivors, just to put that a little bit into context. So there's some lovely articles that you can see that actually was comparing aviation and healthcare in terms of patient safety. And I like this statement out of the ERA report: medical mistakes are human mistakes committed with a human system inadequately designed to catch and neutralize those mistakes in time. So humans will always make mistakes, regardless of your training, your experience, or how determined you are. And how do we catch those mistakes? So the one aspect which we're not going to talk about today is checklists. And a lot of the airline checklist systems is also found its way into medicine. But the second aspect is this organizational culture. So human makes mistakes for all kinds of reasons. It might be a misperception. It might be making an assumption of something that you think is already going on or what you think somebody else has done. It might be a miscommunication, either not reading the handwriting correctly or mishearing what you think somebody has done. But the important thing is that apart from the fact that mistakes happen quite easily, is that when we are under pressure, these mistakes increase dramatically. So when you already have scenarios where you are under-resourced, where you do not have everything you need to actually do your job, where there's a lot of other pressure going on, there's even a higher risk of making mistakes. And we can see this with the challenges, for example, with the amount that we're having to spend on litigation cases. When you look at major medical errors, you will also never find that it's just one root cause or one major mistake that causes the problem. There's usually a host of contributing factors that happens, and no one is immune. So picking up mistakes before they happen or preventing future mistakes relies on an organizational structure and culture that's willing to actually catch and prevent those mistakes. So let's start thinking a little bit about how culture might contribute to this. And I want to compare and contrast two types of work environments that we might say. The first one is a depreciative work environment, and that we define as a work environment where a significant number of the interactions are negative and depreciative. So what's interesting when we talk about organizational culture is it always has to do with humans and how they interact. Your culture is not created by how busy you are or what resources you are or what pressures they are. Those things do play a role. But what creates culture is how people behave. So depreciative interactions will include things like criticizing or manipulating or gaslighting or stonewalling or ignoring, any sort of action that actually devalues somebody else and basically makes somebody else feel worse. So when we think about, and what's interesting is it doesn't mean that all the interactions have to be like that. And there's interesting studies that sort of talk about what ratio do you need for an environment to be actually feel like a positive environment. From, you need at least 4 out of 6, for example, or 5 out of 6 interactions need to be positive to counter the 1 or 2 negative interactions. So these are the kinds of underlying beliefs that might be prevalent in a depreciative learning environment. And they're not necessarily the cause, but they're sort of linked to what happens when we are in those learning environments. So the classic one, and we all have that, is, where people, new young doctors come into the department or new young staff, and there's this attitude of, you should already know that. So that's the typical comment of, why don't you know that? Or why have you not been reading? Or where have you, where have you studied? And sort of devaluing that person already when they're arriving in terms of their knowledge. There's this idea that we can motivate people to study through humiliation. So if we show them up of how little they know or of how pathetic they are on, for example, a grand ward round, that's going to help them go home and open the books. There's something called the Navy SEAL imperative, very much liked by our surgical and emergency medicine colleagues. The idea is, throw them in the deep end, put them under massive pressure. The only way to learn how to swim is actually throw them into the deep end. The idea that people learn by telling them stuff. So you give them a lot of instructions and then they'll know and they'll do it after that. What I'm calling the hierarchy imperative. So you always learn from cleverer people. The top people in the hierarchy will teach the bottom people in the hierarchy. And all of this is part very much a fixed mindset where we look at people and go, some people have got it and some people don't have it. And you treat people basically already with prejudgments when they arrive. Yep, that person is obviously quite competent and making a decision early on about who can or cannot learn. The word toxic workplace is, I'm using one of the definitions here, which actually will describe sort of an extreme version of the depreciative work environment, when you would actually have proper infighting or intimidation or actual affronts that actually harm productivity. And quite often we use the word toxic quite loosely, to even just describe these depreciative work environments. And there's obviously levels between just a negative working environment to the point where it's actually toxic. So what happens if you have a depreciative work environment? And there's been a lot of evidence and research around that, but you start having the challenges that in that kind of environment, clinicians don't ask for advice. They fear humiliation or rejection or attack, and so it's better just to keep your head down. You also find that clinicians are terrified of making a mistake, and therefore they are much more likely to admit a mistake and feel disempowered to manage a situation when they are feeling out of their depth. Clinicians are also not inspired. We'll talk a little bit about emotional spaces in a minute, and the seek space is our curious, exploring space, and people are not, they don't feel curious or eager to learn, they lack motivation, they do not consider their seniors as resourceful, and when they come home, they actually just want to forget about their day's work. Very important, it's definitely linked to higher rates of medical errors, and also linked to higher rates of anxiety, depression, and burnout in clinicians. So what we want to aim for, and what we're going to talk about tonight, is what I'm calling an appreciative work environment. And this is where the majority of human interactions are positive, generative, and affirming. So this can include giving compliments, taking an interest in each other, humility, kindness, generosity, affirmation, sort of these higher qualities that we see within relationships. I just want to make a little aside that you can create an appreciative work environment even in a very hierarchical, strict, top-down, high expectation department. So I've had complaints from, again, some of our sort of hardcore surgical disciplines that they're not sure about fluffy. You don't have to be fluffy. You can still have very high expectations. And this is not so much about how you run your department, but it's about how you interact with people rather than what those expectations or interactions are. So the underlying beliefs that we are building towards is that we actually believe and there's no such thing as a stupid question, which means that when an intern does ask you something or a ComServe that is you think that they shouldn't be knowing at this point, that you're not rolling your eyes, but that you are great that you've asked that question and you are willing to really support them no matter what questions they ask. That we motivate people through affirming what they already are doing well, and within that context help them to understand their gaps. That we don't just throw them in the deep end, but we actually prepare them, for example, through drills, by doing your ATLSs or your ESMO-Es before you put them into high-pressure situations. That we understand that people actually learn through reflection. We don't just instruct them, we actually give them things to read and think about, and they learn a lot from their own reflections on experiences. The idea that you can learn from anybody, you can learn from an experienced nurse within your department, you can learn from somebody from a completely different discipline. And the growth mindset is this idea that anybody can learn. So even if you have somebody starting at your department that seems to have a certain deficit of knowledge in particular areas, that if we give enough commitment and time, they will also get there. And what an appreciative work environment does is it creates an environment of trust. And because it creates trust and safety, we now have a possibility that somebody is more able to actually ask questions and to be able to when they're feeling they're making a mistake or when they're worried about something that they don't know, that they are going to feel free to actually come and approach the senior doctors or other people in the department. So how do we do this? The interesting thing about when we talk about cultures and I talk about learning work environments, we all want to show up to a day at work where things are great. We want to show up at a day of work where we all work with a team of people where we all get along well. But why don't we do that? Why do we end up having environments that can feel so negative? So I'm going to introduce a concept here tonight called emotional competence. This is particularly very much out of my own work, something I've started with in my master's and would be taking into my PhD. And I'm very curious and interested in how we teach emotional competence, and I've spent the last few years trying to study and understand why people behave badly. So what we're going to spend a little bit of time on is being able to understand why we are not so nice to each other and understanding how some of these unconscious things play into these very toxic workplaces. So the emotional competence is, I find, a more useful term than emotional intelligence. And when I'm looking at how we teach, how we work towards somebody that is emotionally competent, I'm going to look at 3 different levels. So firstly, to be able to become an emotional competent clinician, you have to have some emotional insight on understanding how emotions drive behavior, and we're going to look at that tonight. You also need to be able to start recognizing when emotions start arising in real time. And then competence is being able to modify the behaviors that are driven by those emotions. And we're going to touch on all three of these this evening. So let's start off with emotion and behavior and have a little bit of an understanding of why people, and sometimes even you, can be such a pain in the ass. So when we do the clinical supervisor course, there's a QR code at the right here, saboteur self-assessment. I will also, at the end of the course, I've got a little online YouTube, well, a little website where you can actually work through these modules in much more detail, and all of the codes and links are on that little website. But there's actually a way of actually being able to understand your own behaviors that are created by emotion. So those of you that know me would have come across this little particular conceptual framework that comes from the field of affective neuroscience, that being able to understand how stress affects the brain. So as human beings, we always operate every single time in one of two different modes, depending on whether we are in survival mode, so whether we're under stress, or whether we are in executive mode when our stress levels are nice and low. So, for example, our survival mode is very much dictated by our limbic system and our endocrinological system, and we have those basic fight, flight, freeze systems, as well as our basic drives form part of our survival system. I'm going to go through these very quickly. When we are in survival mode, it does not only affect our physical changes, but it also affects our perspective on how we look at the world and how we think. So our view of the environment around us becomes very vigilant, it becomes very narrow focused, and it becomes very self-centered because we're thinking in terms of survival. And we have very particular negative emotions that arise, which I'll look at in a moment. And these negative emotions are going to be linked to specific behaviors to help cope with those emotions. So what happens when we are in survival mode is we become more aggressive, and this is where we're also at our most dangerous, and we're also at our most stupid. And I like to describe this as our worst self. So the analogy that I like to use in my courses, especially when I train my teenagers, is imagine you have this sort of inner survival dragon that is supposed to be responsible to keeping you safe and has these very specific emotions and behaviors to help you do that. On the other hand, we luckily don't only have a limbic system, we also have this prefrontal cortex, comes much later in our development. And this prefrontal cortex has these higher order substrate capabilities. So we're capable to executively plan, we have the capability of empathy, we have the capability of reflection, and we're able to control some of these lower impulses of our lovely dragons. So our prefrontal cortex makes it possible for us to engage in rational high-order thinking. And from this view, we have a different view of the world. We're able to see things with perspective. We're able to see the bigger picture. I'm going to talk about the positive emotions that are linked to these. But the qualities that arise when we are in executive mode, when we're in this dragon master mode, is qualities such as agency, reliability, humility, being able to be compassionate, creative, flexible. When you are your best self, when you are supportive and loving and at your most intelligent, you can be sure that you are in executive mode at those times. And the important things to realize is that these two modes, you flip between these modes with this lovely little switch that is controlled by adrenaline, is going to determine whether you are facing the world in your worst self or your best self. So when we're going to look at emotion and behavior, affective neuroscience is very good at describing some very basic primal emotions that drive certain biological impulses. So emotion actually has to do with motion, and it's trying to get you to do something. And Panksepp has identified very specific neuropeptides that's linked to specific primal negative emotions and specific primal positive emotions. So the negative emotions we want to watch out for, and is the ones that come into play when you're in a toxic environment, is firstly fear. So that's your biological impulse to move away, and of course includes any anxiety or worry that you might be experiencing. It includes rage, which is the biological impulse to destroy an obstacle in your way. And we've all felt what that's like to be either on the receiving end, and we've all had those little impulses of wanting to destroy obstacles in our way. And then distress, which is, we also have all of these emotions in relation to animals as well. And you can imagine when you lose a carer, for example, or when your carer is out of sight as a small child or as a small animal, it creates this extraordinary emotional pain to make you want to cry out. So it's actually a biological impulse to cry. And very important is that it's featured by this emotional pain. People who are, for example, in depression might actually be stuck in a state of distress, and therefore also has to bear this extraordinary pain with its high risks of things like suicide. So very important is that these emotions very much come to the fore when we are in survival mode and is very much reactive. But we are also able to access positive emotions, and these are biological impulses that actually, although they come from our biological part of ourselves, they're very much linked to our higher self. So our care is our biological impulse to give and receive care. So if you as a doctor are providing care for a patient and are feeling warmth towards a patient, or if you are receiving care from somebody else, and we know that's oxytocin mediated. Play is the biological impulse to enjoy something, to do an activity for its own sake. So with small animals as well, there's a lot of play that helps them to build their own tribes and their own skills within a group. And very much everything to do with culture and sport and hobbies very much belong to this aspect. But I want to really highlight this positive emotion of seek, which is linked to our primal need to be curious about our environment. And we actually have a biological impulse to explore or to solve problems or to discover things or to learn. And this is the basis for curiosity, problem solving, and exploration. When we are talking about learning environments, this is the space that you want to be in. You want to be in a space where you are curious about how you can help the patient in front of you. But these emotions we can only access when we're actually within executive mode. So the counterproductive behaviors that are linked to these emotions, and I'm going to go through these very quickly, and there's more than enough space to go and look at it. If you want to go and study these in more details, please, you can look at Shazar Chamin's book. But he basically described these very particular behaviors that we have that helps us cope with these hard emotions. So there are flight mechanisms. So a classic one is when you're feeling anxious, you start criticizing everybody else and others, and that makes you feel better. You get your hyperachievers who might overperform. Your ambitious people who need to be the best in everything also helps them to feel less anxious. For those of us who love lecturing, you might have your little hyper-rational kicking in. So that's your typical mansplainers. We've all had that patient who's not adherent, and you think by giving them a long lecture about why they need to adhere to treatment makes you feel better, but is not necessarily going to help your patient. If you're somebody that's very organized, you might go into controller mood when you're anxious. You start manipulating everybody else around you. This is also what underlies things like gaslighting and outright bullying. And very important is that you actually have a dopamine reward for engaging in these activities that's going to help you feel like you're managing the situation. For people who do not particularly like getting into conflict situations, you get your pleasers who might be sacrificing their own comfort and self to be able to try and mediate a situation. Some people find by getting over-obsessed with their own environments, so all your obsessive compulsive disorders, your perfectionists are ways of also dealing with those strong emotions. And I think we've all had the 3 o'clock in the morning when you're lying awake worrying about all kinds of different things and becoming hypervigilant as a way to try and manage difficult emotions. Some people also have flight mechanisms that they might engage with. So you might just avoid the situation altogether. Might feel terribly sorry for yourself. We've all done that at 3 o'clock in the morning. Or you might distract yourself. So the root of all addictions is actually a mechanism that somebody's using to try and manage one of those 3 very negative emotions. So if we put this together now in terms of what happens. So the original design of this whole system had to do with physical threats. So stimulus, something happens. I like to go running on the beach on the weekend. If a dog runs towards me barking, I will get a bit of a fright, and I might go into a specific emotion. So the emotion that gets awakened is the biological impulse to move away from this threat. And that's going to go into behavior. I'm either going to shout at the dog if I'm going to try and fight it, or I'm going to freeze, or I'm going to run away. This might all be very sensible when you're in a physical threat. The problem is that when we use some of these very same behaviors to try and manage very complex scenarios in relationships. So Shasad calls them saboteurs because these particular behaviors usually makes the situation worse. It doesn't make things better. So for example, I have an argument with my partner. It also creates an emotion, either fear or rage or grief. So there's this unpleasant emotion and I have an impulse to manage this emotion. And now that relates into a behavior. So now I might either criticize him or I might stonewall him or I might give him a long lecture about everything that's wrong with him and guarantee that's definitely going to make that scenario worse. So this is just a small aside in terms of using this framework and why I've been looking at emotional competence within education, because we quite often wonder when we are looking at training our young doctors and we're talking about how do we train these higher order skills. So how do you train a doctor to be compassionate or to be humble or to be generous or to be reliable? And so if we use this particular framework where we assume that when people are behaving badly in a way that is destructive or unhelpful, that actually this has got to do with them being in survival mode and these emotions and counterproductive behaviors are taking over in that moment. So the dragon is in charge. Where actually when people are in executive mode and then they are able to actually manage these negative emotions, they're able to generate positive emotions, and now they are able to be honest and reliable and kind and helpful and have access to these higher order qualities. So the idea is then is we don't have to teach people how to be compassionate or teach them how to be humble or explain to them why it's a good idea. All we need to do is teach our doctors how to manage that survival dragon, how to manage those emotions and counterproductive behaviors. And that's what I mean by emotional competence. And we are going to look a little bit more at this just now. So let's start looking at some of these things that are actually feeding into. So we've already looked at how behaviors and emotion might feed into a toxic environment. So let's look at two other things that's going to be playing in. And I want to talk a little bit about unconscious bias and power dynamics. So there's a lovely article that's just been published by Prof. Mkhaga from Worcester University about unconscious bias and postgraduate specialist assessment in South Africa. And she defines unconscious bias as making decisions, interpreting situations, and forming assumptions about people based on past experiences, stereotypes, ingrained thoughts, and deep-seated ideas. And you can see that unconscious bias is actually a function of your survival system and is part of our drive to find a tribe in which we will be safe. So just like the animal kingdom, we have a biological drive that says we need to be in groups to be safe. And the way to figure out which group you're going to go to is find people who look similar to yourself. This is not necessarily a sensible way to decide if somebody is safe, but it's biological. What can you do? So the idea is when you go into a new environment or an environment where you feel unsafe, you're going to go and look for people who look like you, who speak like you, who behave like you, who's got similar backgrounds like you, and you're going to feel slightly safer with those people. So this drive is what makes us build nationalities. It makes us have identities and flags. It makes us like branding as a particular group, for example. And when you meet somebody or something that is completely new or unfamiliar, your first impulse is going to be suspicious or nervous or skeptical. So we actually have got this sort of part in us that is potentially racist or misogynist or homophobic or transphobic or ableist or ageist, just based on meeting somebody that's very different from ourselves. Fortunately, we do have an executive brain that can counter these unconscious biases. And it's important to become aware of what those biases are. And whenever we create systems where we talk about words like diversity, equity, and inclusivity, we are actually trying to counter these unconscious biases. So the second drive I want to speak to that involves also what happens within the environment is the drive for power. So whenever we are in a relationship with somebody else and we're communicating with somebody else, there's actually a subtle power dynamic that takes place. The more power you have in a relationship or within a society, the safer you are. And so there's a little bit of a need to assert our power in scenarios, in relationships. So that power can be political power. So the higher you are up on the hierarchy of any organization, it can be financial power. The more money you have, the safer you are. And it also includes your sort of social clout these days, you know, how many likes your pages get. And to be able, the frustrating thing with the world that we live in is that quite often, just because of who you are and some unearned factors, personal factors that you have, you might end up being closer to a center of power. This is the wheel of power and privilege. And certain qualities is going to put you closer to that center, which means you have more ability to change the world around you. Some people, just because of unearned disadvantages, are sitting more on the margins of this power wheel and further away to that center of power. And that's when we use the word our marginalized societies, or people who have much less ability to change themselves or the world that they live in. So when we have hierarchical systems, and remember, all our academic institutions and all our hospitals are very hierarchical, there's already a natural power dynamic. And the higher you are up the hierarchy, the more power you have to influence your workplace and those working under you. So your ComServe doctors is very vulnerable to those power dynamics of people working above them. The term intersectionality talks about how these things intersect. So the more of these unearned disadvantages you have on the margins, the more vulnerable, for example, you will be. So this brings us to two little concepts which are very, very valid for the times we are living in at the moment. And these are two paradigms that arise depending on where you are, whether you are looking at the world from a survival point of view or from an executive brain point of view. So our survival mode is naturally elitist. And what elitist means is it's a paradigm that believes that some human beings have more value than others. So any system or society that believes in supremacy, domination, or oppression, any sort of your actual systems that builds racism and misogyny right into your political systems are what we would call an elitist view, and is very much based on the way our survival mode views the world. The opposite of that is called an egalitarian view of the world, and that's a paradigm that believes that all human beings have equal value. So when we talk about principles such as diversity, equality, equity, and inclusivity, as well as any of the principles of ethics, they belong to an egalitarian view of the world. So we have a very good example in the world as it stands at the moment, that South Africa's constitution is a very good example of what an egalitarian constitution looks like and the protections that it brings. We believe that all human beings have equal value. And we can see the states at the moment, the USA has become an elitist state where some human beings are considered more valuable than others, and those in power decide who is going to be where in that hierarchy. But regardless of paradigms, as each of us as particular people, we will have people that we're going to meet that are very different from us, and that can potentially trigger our little internal elitist mode, which may even conflict with some of your egalitarian beliefs. So this is just a nice little exercise. Again, we're not going to spend time on these exercises. They're all part of my course. But you can have a little bit of a reflection in terms of where are you sitting in terms of, or do you have more of those features that potentially gives you higher power? And I'm quite sure that you're going to tick some of those boxes. And how many of these lower power disadvantages have you got? So for example, let's use Trump as an example, the elephant in the room. If you look at the qualities that he have that might give him more power in the global society of today, being white, being a citizen, being a cisgendered male, being heterosexual, English speaking, rich, owning property, mentally stable, neurotypical, able-bodied, and having a post-secondary education, all gives him much more power. So if you think within our hospitals, for example, you quite often, your senior doctors will have more power quite often than some of the other staff, and certainly the patients that you are dealing with. And we need to become a little bit aware of how do we feel and how do we react to people that might be very different from us. Do we find a natural elitist view that we actually believe they have less value than us? Or do we have an egalitarian view where we override that and believe they have the same value? This is just something that you can go and look up. It's called the implicit association test. And that's quite a fun, in-depth way for you to figure out your own unconscious biases that you might not even know about. So let's start getting into the brass tacks of how do we actually then build an appreciative feedback culture. So what drives culture? So firstly, we've already mentioned this unconscious bias and power dynamics. So if you have particular people within your team that has very particular biases against other people in the team or very particular power dynamics, that's going to play in. And a very, very large part to do is how much your staff on the ground is in survival mode. That includes your clinical supervisors, your nursing staff, your registrars, medical officers, including the stress doctors and other departments you're trying to refer your patients to. All of that is going to have an impact on what that particular environment feels like. So if you think in terms of looking just at that third aspect of stress, so imagine you have somebody in the team that is feeling very unsafe and stressed for whatever reason. It can be things that's happening at work, but it can also be stuff that they're bringing from home. And they have one of these strong emotions that are dominant, either fear, they're either anxious, or they're very irritated, or they're very upset about something. This now might lead to these counterproductive behaviors we mentioned earlier, and they might find that they're criticizing other people, or they're preaching at people, or they're trying to manipulate those around them. Might be stonewalling, ignoring somebody, they might be feeling sorry for themselves. And what that does is it makes somebody else in that interaction feel unsafe. That person becomes stressed, they might themselves become anxious or frustrated or upset. That leads to their favorite counterproductive behavior, and round the merry cycle we go. And suddenly we have a lot of very unpleasant interactions happening on the shop floor, and this contributes to this very toxic feeling. So very simply, actually, all we need to know about toxicity is it's stress that creates toxicity, which then creates more stress, which then creates more toxicity. So we need to start becoming aware about what might put our staff in survival mode. And anything that's going to make a staff member feel unsafe on any level can trigger that. So that can be physical threat, and that includes verbal abuse. So shouting at somebody or being verbally abusive to somebody in the team is going to make them feel unsafe. But also, even if you are just rejecting somebody, excluding somebody, being sarcastic or rude about somebody, that emotional threat will make them feel unsafe. Or when you're actually humiliating somebody or insulting somebody or actually discriminating against somebody because of who they are. A very important thing to realize is that there's obviously outside things that's going to make people feel threatened. But there's also different people are different in how sensitive they might be to threat. And I want us to get away from this idea that sensitivity is somehow a negative quality. So quite often we will talk about somebody being too sensitive, we'll talk about snowflakes, but actually sensitivity in itself is not the issue. And quite often it's your thick-skinned people who can sort of take anything that comes at them, that might sometimes go, well, actually, no, they should just not be that sensitive. But we need to create an environment where our more sensitive members are also safe. So that includes our more junior staff. So the lower you are on that hierarchical rung, the more vulnerable you are to threat that might be happening. There might be stuff going on at home that we don't know about. So they might be having difficulties within a relationship. There might be financial stress and stuff going on that's making them very sensitive. People might come with history of trauma and abuse and get triggered by things happening within your department. They might have health issues, whether it's physical health issues that they're struggling with or mental health issues that you might not even be aware of. And then our neurodiverse colleagues. So if you've got somebody who's autistic or who has ADHD, there's even a recognized called rejection sensitivity dysphoria, where there's a high sensitivity to rejection or to criticism. And we need to create an environment where, how do we create safety for all these different people? So this is also, again, we can't spend time on these reflections, but I want you to think a little bit about one of the workplaces you're at, whether it's a particular ward or outpatient department, and just think a little bit, if you had to scale it on a scale from 1 to 5, how supportive or toxic is the place that you work? And you can think on average, because actually it can vary from day to day, depending on who's on the floor. Are you in a place with no trust and you would actually call it toxic? That's a 1. Is it just a bit of an unpleasant working environment, quite stressful relationships? Is it neutral? It's not awful, it's not great. Is it quite pleasant, like going to work, no major conflicts? Or is it one of those awesome places where the whole team's just pulling together? And if you've identified where you are at, it's quite interesting then to reflect on what are the factors that's created that particular level. Unconscious biases, power dynamics or not, if you're on 4s or 5s, and what kinds of stress is there that's happening on the ground that might be contributing to that. So a little bit of homework to go and think about. So if we want to shift toxic work environments, I'm going to look at 3 aspects. We need to look at physical factors we can possibly change. We're going to look a little bit about role modeling and the impact of that. And then we're going to look at some practical things about building affirmative work teams. So firstly, physical factors. So interestingly enough, a clinician awake for more than 21 hours has a worse performance as a person with a blood alcohol level that is over the limit. And we need to be able to understand what that working environment is like for people on the ground. And I think especially if you're quite senior, if you're like a clinical manager, for example, it's actually useful to get feedback from your staff on working conditions. For example, we once realized that none of the interns was actually taking lunch. They hadn't realized they could take lunch and they were just working through. So we need to consider things like the hours that they're working, breaks, lunchtime. This whole mess with the commuted overtime is making us relook at things as well. But also in terms of
Madeleine, we've lost your voice.
Oh, okay. I can see my
Okay, now you're back. You're back.
Great. Sorry, that was just my internet. So I'm just giving you a few things you can consider when you think a little bit about the physical factors. Can you make your working environment better? The second thing is to think about is in terms of role modeling, and this is the tricky bit. So the challenge is that the tone in your department is set by the most senior people. So actually, it's the person who's in the leadership positions and then the supervisor positions that's actually going to set the emotional tone for that team on that day. And that's quite a responsibility, actually. So if you've got a team leader, whether it's the person in the ward or the OPD or the casualty, and they are critical or grumpy or irritable or negative, and they're leading the ward round, for example, that is going to create a very particular feeling in that particular space. The opposite, if you have a team leader that is
And Madeleine, you are going in and out with the speech. I can't hear you. Okay, Madeleine, we still can't hear you. I'm just going to message her and see if she is offline.
Sorry about that, Steph. Where did you lose me?
On this slide. So we haven't heard anything on the slide.
Right. So let's just talk a little bit about role modeling. And the challenge is the challenge and the opportunity is that the senior in that particular department or the person that is the team leader in that particular setting has got extraordinary power in the tone that it sets for the rest of the department. So imagine if you have a ward round and the person who's leading that ward round is critical and grumpy and irritable and negative and nasty to everybody, that's going to set a very particular tone for that whole ward. But the opposite, if you have somebody that's very enthusiastic and supportive and engaged, that's going to create a very different feeling. So actually, the higher you are within the hierarchy, the more you can affect what's happening to those below you. This is also important, even if you're just still a ComServe in your hospital. If you're on call and casualty in the night and you're the most sort of senior doctor within that casualty, then you're actually leading the team. And again, the emotion and the behavior you're bringing to that team is going to be affecting everybody else. So let's look a little bit at some of the skills we can bring to actually shift that. And the first skill I want to talk about is this ability to have what I'm calling dual awareness. So we have this extraordinary skill as human beings that we can think about our thinking. And we can become aware of a negative emotion or a counterproductive behavior. And we want to learn to do that as early as possible. So emotions are very subconscious. You know, you do something and shout at somebody before you've even thought it through. And the first skill we need to learn is to be able just to notice, okay, right now I'm angry, or I'm anxious, or I'm upset. Just noticing the emotion gives you a choice in how you're going to respond. And if you can observe this ability to observe from your executive self, the way that you've known that you've got to that level is you're able to experience a feeling of compassion and curiosity, then you know, okay, now I'm able to observe myself from this dual awareness level. So when you think about this within action, you want to be able to get to a point when a conversation is not going well, that you're just able to catch yourself and go, hold on, hold on, hold on, hold on. Things does not feel right. Is this me in survival mode, or is my registrar or partner, colleague, child in survival mode? And is that why this conversation is going downhill? Once you've noticed that, you'll be able to catch yourself and know you cannot fight fire with fire. And just not bringing your own counterproductive behavior to that scenario can help to at least make sure you do not make the situation worse. You do also have a master self superpower that you can use when you are dealing with other people's dragons. And this particular superpower is your compassion. So if you're able to reach that master self level and you're able to bring compassion to somebody who is very stressed, what is happening in that scenario is you're actually bringing a possibility to restore safety to that person. So remember, we said our dragon self or our worst self has got something to do with us not feeling safe. If somebody approaches you with compassion and graciousness, it gives you the possibility to feel a little bit safer and to pull yourself together. So we want to be able to accept that dragon and to be gracious and to recognize and affirm the emotion that this person is feeling. And the emotion, therefore, that you are looking for is how do we bring calm, warm curiosity to these scenarios? So then when we talk about emotional competence, and we're sort of getting towards the last few things now, where we look at how do we actually now manage this strong emotion? So we're in distress. How can we get ourselves back to sort of a calm, compassionate state? And the important thing to realize is that this is all caused by hormones. Your body is flushed with adrenaline, and as long as you've got adrenaline, you don't have a brain. So the only way to get your brain back is to actually get the adrenaline down. So we all know the little stress cycle where your adrenaline causes your body to actually change. Remember, your blood pressure goes up, your muscles go all tense. You start seeing threat in all kinds of weird places, and this keeps this cycle going. And there's therefore two places where you can interrupt your adrenaline sort of feedback cycle. The one is managing the biofeedback from your body. So as long as you're breathing really fast or you've got severe muscle tension, all of that is actually giving a message to your adrenal glands that you are still fighting. If you can actively relax your body, and there's lots of lovely apps with relaxation exercises, but anything you like doing, exercise, yoga, stretching, that gives you actually the possibility to relax this body and being able to just switch off your adrenal glands. The second thing you can do, and it's quite nice if you do the two together, is finding a way to clear your mind and not start thinking about all the things that's going to go wrong. And there's a lot of work done around mindfulness, meditation. You can use prayer to help quiet your moment by focusing very strongly on a sensation in that present moment and to help clear your mind. Oh, there we go. So the third aspect we wanted to look at is how do you actually then grow a supportive team? So you now might be a clinical leader in your team, and how do we actually start building these affirmative teams? And I think what we need to do is quite often we have our higher values, we've got our Bato Pele, but actually to start making these higher values something that we really foster and work at how do we build these higher values into our departments. So if you have a value of inclusivity and respect, being generous in assumptions, then that has to be a lived reality in your department. And you want to say to people, in this department, we are kind to each other. We do not unnecessarily criticize or humiliate or devalue somebody else. Our course at the moment that we are doing is very much about when we have to give feedback, when people do have gaps or these things we need to look at. There are ways of giving feedback that can still be very clear and be very good at helping people learn, but then can be done in such a way that it's supportive and affirmative. And you almost want to imagine that how do we create spaces where there are care. So we want to bring warmth and care for each other. We need to be able to make sure there's access to things like counseling and support for when people are struggling. We need to pick up when people are burning out and not managing. We need to create time for social interactions and spaces where we can actually meet up as people, even with our families and with our partners, and get to know each other in more of a social, fun way. And very important is, how do we create an atmosphere where we're enthusiastic about learning together, about research, about teaching, and where it's not about showing people up for how little they know, but about getting excited about learning things together. So just as another last little bit of homework to think about, if you now earlier had identified yourself somewhere on that level 1 to 5, you can now start thinking, well, what intervention, one of these things we've just looked at, can we do that might be able to improve my particular learning environment to move it up maybe from a slightly more depreciative to an appreciative level. So I'm just going to mention one of the advanced feedback techniques, and we will be sending around, I've got a little video that goes into detail on this technique on something called appreciative inquiry. There's lots of lovely communication skills and techniques. For me, and this is almost a summary of what we've just covered, being able to become aware of your emotions, being able to control these counterproductive behaviors, being able to manage your stress will put you already in a master mode. And quite often just being in that mode will mean you'll be able to be amazing and innovative and creative. But also in this mode, there are amazing sort of higher level master skills that you can then apply. And the one that I want you to go and look up is particularly around appreciative inquiry. So for my last slide, your principles of appreciative feedback is to listen before you talk. When you have somebody that you want to tackle about something, first affirm what is done well and build on that. Be gracious with mistakes, avoid criticizing or belittling, and use each interaction as an opportunity to teach. So great, I'll send you the things on appreciative inquiry. In conclusion, we're wanting to shift paradigms. How do we start building amazing learning spaces? And it's very simple, 2 principles. First, man, know thyself. It's the old Greek adage for all genders, just to be clear. But we have to become aware of our own saboteurs, our own unconscious biases, our own power dynamics, and how that plays into the environments that we work in. And then very simple, we need to be kind to one another. Thank you very much. Now happy to open for questions or discussion. That, by the way, is the QR code for if you want a lot more detail on emotional competence and some of these reflection exercises.